Hey, it's Dr. Centeno. Thanks so much for joining us today on this Sunday morning here, Colorado time on the East Coast. I think it's noon, and back on the West Coast around 9 a.m. So today I've got an interesting topic. Going to talk about imaging measurements that define CCI and talk about all things imaging and CCI. We'll also talk about pretty much anything you want to. Questions after this can be about CCI. I already have a bunch coming in already. Questions about, or for me, can be really about anything regenerative medicine as well. But we'll start with about a 15-minute discussion on imaging in CCI. And then from there, we'll go into Q&A. So if you want to get your questions in early, this is a good time to do that. If you haven't been here before, then how you do that is if you're on YouTube or Facebook, just go ahead and make sure that you put your question in as a comment. I'll then see it here and I can put it up on the screen and answer accordingly once we get to that part of the broadcast. So again, if you are on YouTube or Facebook, just put your question in the comments. I answer questions as soon as I see them, so they're coming up in order for me. So you're going to want to get those questions in early so you can make sure you get your question answered. So we're going to start with this concept of imaging and CCI. And this is one of those topics that is kind of all over the map. I mean, I have to tell you, it's a little bit of a mess right now. I've spent the last 10 years trying to dial this in and to try to find as much evidence for the types of imaging that we use to diagnose CCI at the Centeno-Schultz CCI practice as possible. But what I also see out there is there's a lot of misinformation or half information or old information, or it's what we've always done information. So let's get into some of that, and then I'll do Q&A after that. Again, remember, if you have a question, put that in the comments right now. And if you're on YouTube or Facebook, I'll see it here. And if you get your questions in earlier, they're more likely to get answered than if you get them in later. So let's go through this whole thing we're going to talk about today of imaging and CCI. So imaging measurements for CCI are kind of all over the map. And what I mean by that is that we have huge decisions being made based on these imaging metrics, right? You can have a high risk upper cervical fusion that gets done based on imaging metrics. You can have other surgeries that get done, and yet there isn't a lot of uniformity in really holding physicians' feet to the fire about what's probably normal and what's probably abnormal. And we're going to get into that today. So what's a good CCI measurement? Let's start there. Well, the first thing would be obvious, right? That this would be rarely or really never found in people walking around with no symptoms. So that one just makes sense. If I can take 100 people off the street right now and we make up a measurement for CCI, but 40 of those people who don't have any CCI symptoms, they're fully functional, they're living their life without any problems, have that measurement, then that's not a good thing. That means that our measurement is wrong, our measurement is inaccurate. So you want to make sure that that measurement is rarely or never found in people who are just walking around the street with no symptoms. Now that one would seem obvious, but not so much, as you'll see. And then you would really like to see studies that have shown that that measurement is associated with people who have symptoms and rarely found in people who don't have symptoms. As you're going to see, most of these measurements don't pass that second test. We've got some that pass the first test, but not many that pass the second test. And then the third thing is just realizing that all measurements are really just to be taken with a grain of salt, right? At the end of the day, there are people out there who have abnormal measurements who don't really have CCI symptoms, or that's not a good match, and a physical exam doesn't match. And all three of those things have to match for us to get to a CCI diagnosis, or what I call a symptomatic CCI diagnosis. So let's break everything we're going to look at today into some categories. So level 1 category is no or limited evidence that the measurement is abnormal, but many physicians use it. And you're going to see some level 1 stuff here, regrettably, meaning that there isn't research behind the measurement. It's just sort of been copy pasted from one doctor or surgeon to another. And we don't really know where it came from. Then we've got level 2. And that's kind of what we should at least strive for, right? We've got good evidence from research that the vast majority of people walking around the street who have no problems do not have that level of measurement. Because we want that measurement, again, to be rare in people who are just walking around and to be common in people with CCI, to separate out those two groups or try to help us make that diagnosis. And then finally, level 3 is really level 2 plus. We have another study that shows that that measurement is associated with symptoms. That's the gold standard by far, right? We not only want to know that our measurement is rare in normal people and common in CCI, but we would love to know that that measurement is associated with people who have symptoms. And as you're going to see, I think we've only got 2 measurements here that I'm going to go over with you that meet that level 3 standard. So I've really spent the last 10 years trying to source good CCI imaging measurements, and it hasn't been easy, right? I have to tell you, for example, one of those, I've seen countless surgeries for C1-C2 fusion, for example, get launched based on 46 degrees of C1-C2 rotation on a rotational CT scan. And I've seen both 42 degrees and 44 degrees be used as a C1-C2 max. Where does that come from? The answer is no place, meaning it seems to have been picked out of the air based on an old concept having to do with rotatory subluxation, which doesn't really have anything to do with the patients that are getting operated on who have elective CCI. And there certainly is no research showing that anything more than 42 degrees or 44 degrees should be counted as CCI in an elective patient with a rotational CT scan. And yet I know of at least 100 surgeries over the last 10 years for patients that I've met through this whole process of treating and seeing and evaluating thousands of CCI patients who've gotten surgery based on a 46 degree C1-C2 measurement that is stone cold normal when you look at the actual literature. So that's what we're going to get into today, right? We're going to try to parse that out. What's normal? What's abnormal? Why do we think it's normal? Why do we think it's abnormal? I've also had patients who've been very angry at me because some surgeon in Europe told them that they clearly had CCI, and yet they didn't meet any of our research-based measurements to actually have CCI. And you know, I get it why they've gotten angry about that, right? They thought they had found their problem, and they do not want to hear that based on the research, that measurement doesn't look like it's a problem at all. So this is the bigger paper. I'll put this on the Reddit PICL group. If you haven't joined that group, I'd really recommend that you do. That's r/PICL on Reddit. And that's a group where we talk about PICL, CCI, posterior injections, other things related to craniocervical instability. So this is my master list that I've put together now over 10 years. And these are the references that support that master list. Again, the goal is to trace all of that back to some study, at the very least rock bottom, that shows us that that measurement is not common in people walking around the street and is common in CCI patients. Okay, and something I'd really encourage you to do, if you have a CCI measurement out there, or you have a report that gives you CCI measurements, I created this little app, and this little app allows you to go put your numbers in, and it will tell you if you have CCI or you don't have CCI. So this is the tiny URL I created, tinyurl.com/measure CCI, that allows you to go and very easily determine whether or not you have a normal measurement or abnormal measurement based on the published research, not based on fictitious criteria that some surgeon believes is CCI, but has no basis for that decision. So let's go over the first one, right? This is a common one I see, and I'm going to get into Centeno CCI types here. I created a whole typing system, type 1, type 2, type 3. So this would be Centeno CCI type 2B. And this is DMX APOM overhang. So this is that overhang measurement at C1, C2 that we commonly see on DMX. Now, way back in the day, this used to be 2 millimeters. But as the CAT study came online, Freeman CAT actually, it allowed us to start to change that. And what the CAT study showed was that 3 millimeters of that overhang, and that's where the C1 goes sideways on the C2. So this corner should line up, and as the head goes into lateral bending, we see the 1 go sideways on the 2, and that distance there, the offset, is what we're measuring. And as long as we had asymmetrical distance from the dens to the atlas, 3 millimeters was associated with symptoms, or 2/3 chance of having symptoms. 4 millimeters was a 95% chance of symptoms. So realize that this is a level 3 measurement, right? We have a study that not only shows that this isn't found in normal people walking around out there, but also shows that it's associated with symptoms. So this is one of those gold standard measurements. And until someone does a better study, this is what we have. And I think it's quite a good measurement for that reason. Another one is Atlanodental interval. This is going to be a level 2 study where we know it is not found in normal people walking around out there, but we don't know that it's associated with symptoms. This is Centeno CCI type 2A. Now notice here, what's super fascinating about this measurement, and remember, ADI is the distance between the atlas and the dens, and it's being measured right here. So that distance between the atlas and the dens is what it is we're measuring, and normally it's measured in flexion because that stresses that ligament, and this is the transverse ligament that helps to control or keep this ADI small. Now, notice what's super cool here is that we have an age-based guideline. And that means that at the end of the day, this is a cartilage-bearing joint. And as the cartilage wears down and the patient ages, the space gets smaller. So, for example, 2 millimeters in a 25-year-old is a normal measurement, as you can see by this chart. Whereas 2 millimeters in a 55-year-old is an abnormal measurement. So again, this space gets skinnier and skinnier as the person ages. So what's normal for a 25-year-old is very different with regard to what's normal for a 55-year-old. Now, I see very few people that have adopted this age-based measurement standard. Most people are still using the concept that this shouldn't be more than 2 millimeters. But 2 millimeters in a 25-year-old is normal. So this is a great paper. It's in the references, and we need to start changing our assessment of what this ADI should be. I see a bunch of questions coming in. Thank you guys for asking those questions. Do me a favor, give me a like, and obviously your comment can be putting a question in. and subscribe where you are, because that's how we help patients find this content. If you want to pay it forward in the CCI community, the way that you pay it forward is that you make sure that other patients can find this weekly Facebook Live, YouTube Live. And you also make sure that other CCI patients who are just searching for stuff can find this. And you do that by giving that little thumbs up like. So thank you for doing that. So let's go back to our discussion. Now, this is an interesting one, C2-3 translation, inflection, and extension. This is level 2. And translation is this sideways motion of 2 going sideways on 3 that you can see here. So if we put a line at the back of 2, we put a line at the back of 3, we can see that 2 has gone forward of 3. Now, this is a huge amount of measurement here. But what's so interesting about this measurement is that the C2-3 level is very different than the rest of the levels in the cervical spine. If we were measuring this at 3, 4, or 4, 5, we would have 3 or 4 millimeters of wiggle room before we knew it was stone cold abnormal. Whereas at C2-3, it's much more stable. So all we get is 0.7 millimeters in flexion and 0.7 millimeters in extension. So it doesn't take much sideways front-back movement, translation, to become abnormal at 2-3. And this would be that Centeno type CCI of 3A or 3B. Now we get into clivo-axial angle. And this is where we start to see a lot of tradition and less science. So the good news is the number I'm going to share with you is science-based, based on the Nicholson et al. Study. So that's level 2. But we see numbers out there that basically say that any CXA below 135 is abnormal. And there are 2 studies out there, or multiple studies out there. But the problem is that these studies came in before we had upright advanced imaging. So the bottom line was these numbers would be different for someone who is lying face up in a tube on an MRI or lying face up in a CT scanner versus an upright CBCT with flexion and extension, or an upright MRI with flexion and extension. So the Nicholson study is an upright MRI with flexion and extension, and it allows us to repeg this number now at around 125. So bottom line is, if it's between 125 and 135, I would call it suspicious, something to maybe be concerned about. If it's 125 or less, then it's very concerning. But realize that just coming in and saying if you've got a 133 clivo-axial angle, and that means you've got CCI, is probably not tenable based on the newer research, because normally this is measured off of upright MRI. So clivo-axial angle, just so that you know, is again this angle here between the back of the dens and the clivus, which is this thing here. It's basically the degree that your skull is rotated forward relative to the upper cervical spine. And the concern there, based on Henderson, and you'll see the Henderson study is in my references, is that once we get close to about 120 degrees here, we get too much pulling force on the medulla and the upper cervical spine, and that can cause some neural injury. So again, 135 to 125 start to get to be suspicious, and 125 or less starts to get concerning here. Now we've got Grabb-Oakes, and this is another level 2 measurement. And what's interesting here is that, we have patients online who have floated the idea that all you need is 7 millimeters here or above 7 millimeters. Just so we know what we're talking about, a Grabb-Oakes is really just a line drawn from the tip of the basion here down to the posterior inferior corner of C2, and then a line from there drawn to the back of the den. So this is the Grabb-Oakes here. And what's interesting here is that Again, most surgeons have traditionally used 9 millimeters here. We have some patients who have pegged it as low as 7 millimeters based on one study that was, again, done with people lying face up in a tube. And the Nicholson upright MRI study really moves the bar to say that in flexion, it should be 10.5 millimeters and 11 in neutral. Now, what you could certainly say is that if you're between 9 and any of these numbers, 10.5 and 11, then again, it should be suspicious. But there are people walking around out there that have that Grabb-Oakes who don't have symptoms. So we have to be careful with using more than 9. And if we want to be stone cold sure that the Grabb-Oakes is abnormal, we have to use this 10.5 and 11. And the status of the brainstem contact is important, right? Because this dens can go backwards towards the upper cervical spine here, or spinal cord and medulla. So that's another thing we have to take into account. Then we've got the BDI, Bayesian Dens interval, used by a lot of the surgeons that treat vertical instability. And there are maxes here of 11 and 9. But the bottom line is that most CCI patients that I treat and deal with won't get above those maxes. It's really more the BDI difference in flexion or extension, or what's called translational BDI, that's important. Now, the good news from the Nicholson study, the upright MRI study I've been talking about, is that this was a fairly preserved motion from flexion to extension. So what this means at the end of the day is that it doesn't take much difference, just greater than 1.3 millimeters, to be abnormal there in translational BDI. So again, BDI is just the distance between the Bayesian, meaning the tip and the front of the skull here, and the dens, or Bayesian dens interval. And translational BDI is what most patients are going to key off of if you're looking for something that's probably going to be abnormal in the average CCI patient who's getting an elective procedure. Then we've got the BAI. Now that's going to be a little bit like the BDI, the Bayesian axial interval. Now we go from the Bayesian to a line drawn at the back of the axis, or back of the dens here at C2, and that's the BAI. And again, there are maxes here. Most patients aren't going to exceed these maxes. Most patients are going to get diagnosed based on that difference, or translational BDI, between flexion and extension of 4 millimeters or greater. Now, some surgeons will use 1 millimeter here, but that's not research-based. If you look at research-based numbers, it's 4 millimeters or above. So again, if we use 1 millimeter, that's a level 1 measurement, meaning we don't know where that came from. There isn't good data to back it up on an upright MRI, but it's being used. And if you want to use level 2 information, i.e., we know that that's not common in people walking around out there, it's 4. Then we get into rotational CT scan. That's where you're upright in a CAT scanner, and I'm sorry, not upright, but lying face up. And then they turn your head maximally to the right, take a picture of C1 and C2, turn your head maximally to the left, take a picture of C1, C2. Now, this is the one I talked about early on. I've seen surgeons use 42 degrees here, 44 degrees. It's not, guys. This is the only research level 2 base number at 54 degrees or 56 degrees. We'll call it 54. So that's, again, this angle, or the difference between rotation of C1 and C2 on a CAT scan when they're turning your head right or left. So be careful here with this one, because lots of surgeons say this is abnormal if it's over 44 degrees, but 46 degrees is normal based on this Dvorak study where they looked at what people off the street had. And then finally, we'll end up with this C0, C1 morphology. This is level 3 data, because not only do we know what's normal and abnormal, meaning what we're talking about here is having a shallow C0, C1 joint over here versus a normal C0, C1 joint. So on this side, you can see this is a sort of shallow ball and socket that would be inherently stable. Over here, you have more of a flat morphology, and that's going to be inherently unstable. So if you look at the distance across versus the depth, and you come up with a ratio, we know that these are abnormal associated with symptoms in Chiari patients. A lot of my folks have Chiari. And that over here, that was in the normal group. So this is a level 3 finding, in that we actually have a study that only says you normally don't find this ratio in people walking around the street, but also if it's below this, it's associated with symptoms. So in summary, we use evidence-based imaging measurements to determine if a patient meets the criteria to have CCI. Again, that's not the whole diagnosis, because it's only one piece of a bigger puzzle. And when we do go beyond this criteria, we make sure the patients fully understand that, because we believe that's important. What we don't believe in is basically creating a scenario where we're going to tell someone they have CCI, they could get a PICL, they could get a fusion, but the number is really found in lots of people walking around the street. I think that's a big disservice to the patient. Okay, so let's stop the share here, and I'll start answering questions. Okay, so let's go back to the very first questions here. One, hi, I'm going to have an MRI flexion extension in a few weeks. Do you have any tips besides full flexion extension? Yeah, I think some of the tips would be taking a look at what type of imaging that upright MRI center produces and trying to see if it's relatively clear. Now, I have to say the Germans are far ahead here. You guys have far better upright MRIs than we do here in the United States. Ours tend to be a bit blurrier. Yours tends to be a bit clearer. Another tip is making sure they're actually going to do flexion extension. A lot of European patients go in for an upright MRI and they do every other motion but flexion and extension. So make sure that they're doing that. And then the third is with an MRI, you can't move a lot. And the problem with an upright is that it allows the patient to move. And that's the good news. But the bad news is if you move during this scan, then it's going to screw up the scan. So you'll want to make sure that if you need to take some medication for pain or muscle relaxation, that you do that before you do this scan. Cassian, in CCI patients that won't travel out of state to get a DMX, would you have them get both flexion extension x-rays and flexion extension upright MRI? Could you compare what you get and what you don't get from these two? Yeah, Cassian, I have a whole video on what each of these types of imaging can show us. I wouldn't just do a flexion extension x-ray. I would do a flexion extension x-ray with an AP open mouth view, lateral bending, and I have a video that goes through all of that. And I do think that getting, in that case, an upright MRI with flexion extension would help as well. So those are the things I think we would recommend if you don't have a DMX available near you. Realize that you can also get a DMX if you come out here. Right now, Dr. Katz is doing those for us. In the new year, we'll be doing them in-house right at our site to make it easier for patients. Greg, had upright flexion extension here in New Mexico done incorrectly. Didn't have me go to maximum motion. DMX scheduled with place use a day before meeting you. Will that be enough? Or do another MRI done in Colorado too? You know, I think, Greg, you bring up two important points. The first is that if you're doing any movement-based imaging, you have to get the maximum motion to make that work. So if that is flexion and extension imaging, you're going to have to make sure that they get maximum flexion and maximum extension. And all too often, the rad tech tells people not to do that because it's harder for the rad tech. But you got to make sure that you get as much flexion as possible and as much extension as possible. And the second thing you bring up is what's the likelihood of finding CCI if it's present with a DMX or upright MRI. It's more likely that we'll find it on a DMX than an upright MRI. So if you had to place a bet, I'd say just stick with the DMX. If you're not resource constrained, then you may want to get the upright MRI done here in Colorado as well. But if you had to wager a bet because you're resource constrained, then just stick with the DMX. Casey, in the patients that decline autologous bone marrow, would auto adipose dry be better than amniotic shipped from out of state? Patients that decline. So it depends on what it is we're doing here. So if we're treating a joint like a knee intra-articular, you could use autologous bone marrow or autologous adipose. But for ligaments, you're not going to want to use autologous adipose because that's going to underperform bone marrow. And then I think what you're bringing up is the amniotic or placental or umbilical stuff is a scam, meaning it's basically, it's not a stem cell product. It has no live and functional stem cells in it, even though it's being sold that way. So that one is usually out, and anyone using that stuff is part of fraud and a scam. So you want to stay away from providers who are using it because either they're not smart enough to have gotten a memo that it's dead stuff, or they are actively participating in a scam by trying to convince patients that it's a stem cell product when it's really not, i.e. all those cells are dead. But again, if you're doing ligament work, bone marrow is going to perform better than autologous adipose all day long and twice on Sunday. DMC, would translational BAI of 7 be considered pathological? Well, I don't know about if pathological is the right term. I would say normal or abnormal. So it would be considered abnormal because it's over that 4 millimeters. Hey, I'm going to stop here for a second. Please give me a like right now if you haven't already, simply because that's how patients find this. So if you want to pay it forward in the CCI community, like this right now so that we can get more patients to find this video, because if we don't do that, then it's going to be impossible for patients to find it. Amanda, I'm seeing orthospinology chiropractor in a couple of weeks. He uses a 3D CBCT. I know you can't diagnose upper cervical instability with imaging, but show any signs of a ligament or vertebral artery problem. I've never had this done before, so I wasn't sure what it could possibly show, not just related to CCI. So no, Amanda, it's not going to regrettably show anything with regard to a ligament or vertebral artery problem in all likelihood. Definitely not a vertebral artery problem, and very, very unlikely a ligament problem. So I think while that's going to be very helpful for the orthospinology chiropractor to determine exactly which vectors to use to get you back into place, it will not be helpful in any way, shape, or form in diagnosing instability or vertebral artery problem. Carol, submitted advanced by Harry. In your experience, does CCI get worse over time and affect more structures? Asked because my shoulders seem to now be affected as well. Yeah, so again, these are all things where you have to wager bets, right? Meaning that each individual is different. Most people will get worse over time. You could see some people that get better over time. But if you had to wager a bet, you would wager on the side of people getting worse over time and it affecting more and more structures as time goes on, because that would be the more common outcome. John, there's a lot of talk about the airway as it relates to CCI. Any correlation between narrow palate and limited airway and CCI? I don't know if there's a relationship between CCI and a narrowed palate, meaning at the end of the day, you're born with a narrow palate or not. I think more likely what would happen is that once you get CCI and you happen to be born with a narrow palate, then it's going to cause more airway problems. Now, the CCI can cause airway problems and a narrow palate may cause airway problems. So it's going to be sort of a double whammy, if you will. But there shouldn't be any correlation between the CCI and a narrow palate. More that one makes the other worse kind of relationship, meaning the airway issue worse. Casey, any CCI measurements that you and Dr. Henderson disagree about? I don't know that answer. We've never sort of gotten deep on that. I did send him the app just so that he had it that we use to standardize our CCI measurements. So I don't know the answer to that one, Casey. Zach, have you seen improvements in POTS-like symptoms after treating the thoracic spine? Generally not. Again, POTS-like symptoms, if they're coming from the spine or neck, will generally be coming from upper cervical instability and irritation of the vagus nerve, usually at the transverse process of C1. Now, if doing something in the thoracic spine impacts the way that C1 can perform and become more stable than unstable, then there could be a relationship. But it would be a secondary, not a primary relationship. It's been advanced by Harry. If wearing a cervical collar helps the pain, is there a length of time you wear a collar that would negatively impact the issue? Yeah, Harry, that's a good question. I mean, at the end of the day, we always say that wearing a cervical collar should only ever be done really intermittently. And what I mean by that is that the longer you wear a cervical collar, the more atrophy you're going to get and the weaker your muscles become. And stability is half ligaments, half muscles. So we need that muscular stability as well as we need the ligament stability. So if you're wearing a collar all the time, you're getting rid of muscular stability and you're making your instability worse. So at the end of the day, yes, you have to thread that needle if you wear a collar between wearing it only when absolutely necessary, because other than that, you're going to make your instability worse. Omar, if the posterior arch of C1 touches the skull during flexion and mid-forward slippage C4 over C5, what is the expected injured ligament? And can CCI cause dropped head syndrome? As far as the posterior arch of C1 touching the skull, we don't know that that's abnormal at this point. No one's ever really looked at that. And then I think you're talking about mid-cervical translational instability of 4-on-5. So as far as mid-cervical translational instability of 4-on-5, that could be the ALL, PLL, supraspinous or interspinous ligaments, usually. I guess you could also throw the ligament flavum in there. And can CCI cause dropped head? It's theoretically possible, but I'd have to know a lot more information for context. Casey, any CCI measurements that you and Dr. Rosa disagree with? Dr. Rosa really doesn't get too much into CCI measurements. He's got someone else reading his MRI scans, but in my experience, they're not really into using many measurements. So at that point, hard to say since that's kind of not what they do. Is 4 months post PICL for a Centeno CCI type 1A, good time to start next level, feeling awesome after first PICL, wish I didn't mess around with posterior injections and local providers for years prior, which did nothing. Well, thanks, John. So there's a couple of things to unpack there. First, thank you so much for the update. That's wonderful for me to hear. Second, I think you bring up a very important concept. I see patients that waste thousands or tens of thousands of dollars doing local injections that aren't going to help. They're not going to help simply because they've got a type of CCI that isn't going to be responsive at all to posterior injections. And then when it comes time to do a PICL, they've got no funds left. And I at this point, I just have to say you kind of did it to yourself, right? You were told via this education that wasn't a good idea. You spent 30 grand doing that 5 times someplace where you could have done 2 PICLs for that and been mostly better. And then the third thing, John, that you're bringing up is that a good time to start strengthening? And I think the answer to that is, again, threading that needle. So if you're a higher level patient who can do those laser exercises, as it says on the rehab plan, then you can start to add in some next level and see if you can tolerate it. If it causes you to flare up, then you have to back off. And again, you have to thread that needle between enough activity to get stronger, but not so much that it pisses it off. Greg, along with possible CCI MRIs, showed stenosis in multiple areas of spine. Do they usually go hand in hand? Not usually, no, Greg. CCI is sort of a separate issue from cervical stenosis. Now, lots of people have cervical stenosis. As we get older, let's say in our 30s, maybe only 1 in 10 would have it. In our 40s, maybe 2 in 10. By the time we get to our 50s, 3 in 10. By the time we get to 60s and 70s, 5 in 10. So stenosis is a common issue with aging. It's not always symptomatic, and it generally has nothing to do with craniocervical instability. Having said that, it becomes important because it has to get treated at the same time as CCI. Otherwise, we're not going to get forward movement in that patient. So it's very common that, for instance, we're treating lower cervical stenosis at the same time we're treating the upper neck. Lewis Cook, hi Doc, hi Lewis. Todd Ball, thanks for breaking this down. So valuable, thanks Todd. And for those of you who don't know Todd, I'm glad he's on here because we use Todd a lot. Todd really took the time to learn our procedure and to learn how to work with our patients. He offers online postural work. So we use Todd quite a bit because he has developed rehab protocols that allow him to work well with our patient population. Listen, we have a very difficult patient population from a rehab standpoint. It's extremely difficult because it's very easy to flare some of our patients. So if you don't know that, you're going to have a hard time treating our patient population. So Todd has learned through the School of Hard Knocks how not to flare up patients, how to choose the right rehab plan for that patient's level, which is an invaluable service for us because our patients are so hard to work with. If we put them in traditional PT, 60-70% of our patients are going to flare and never go back. Whereas if they're seeing a PT that understands what's wrong with our patient population and how to align a rehab plan to their functional level, they're much, much more likely to be successful. So thank you, Todd, for all that you do. Lewis, we're in Colorado. Do you have an upright MRI studies completed? Where do you prefer DMX to be completed? Lewis, upright MRI of Colorado is down sort of central Denver area, central to south. We are kind of northwest. And then DMX is currently done by Dr. Katz in Boulder, but as of January 1st, it'll be done in our clinic to make it easier for patients. Carol, it's been advanced by Sherry Scott. How far out is you're waiting for a PICL procedure? For me, I'm currently scheduling in December for the CCI practice in general within CCI, within Centeno-Schultz Clinic. That would be Dr. Schultz and Dr. Pitts. That's going to be much easier to get into within about 4 to 6 weeks, somewhere in there. Mark, how do you feel about fusion reversals? It's not really possible to reverse a fusion. Maybe you're talking about a fusion revision. That's pretty common. So fusion revision is where they go in, they might take the hardware out, or they might change the procedure or add in different hardware. But it's not really possible to go backwards on a fusion because once we destroy the disc, there's no recreating the disc. Greg, my CXI was measured, or CXA, sorry, Greg, was measured at 125. But do remember you saying sometimes they're read wrong, or not only critical piece of the puzzle, really hoping to unravel all this with you. It's been a long road. Well, Greg, I look forward to unraveling it with you as well. Again, as I talked about, imaging is really only one part of that piece of the puzzle. And a CXA of 125 is in that concerning range. So we'll have to take a closer look at that and put it in clinical context for you, meaning that a 125 in patient A may be totally different than a 125 in patient B. Healing is free. Doc Smith, Ching Palace, getting rid of that guy. Carol, submitted advanced by Sherry Scott. Can living on things like aspirin, Advil to deal with the pain affect CCI negatively over time? Yeah, Carol, you bring up a good point. We used to think it was no harm, no foul, right? You took Tylenol, you took a nonsteroidal anti-inflammatory drug like Advil, Motrin, Naprosyn, Aleve, etc., and it just gave you temporary relief, and that was all good. Now we know that if you block the inflammatory cascade at all, and here we'd be talking about aspirin, Advil, Motrin, Aleve, etc., then it's more likely that patient transitions into chronic pain. Why does that happen? Well, that happens simply because at the end of the day, we are creating a scenario where the certain white blood cell type that is supposed to manage pain and resolve pain isn't able to do what it's there to do. So people are more likely to go into chronic pain. In addition, if you're on an anti-inflammatory, when you were trying to have that healing response come in and try to help heal and get that acute inflammation in there to heal, then that is going to cause a problem because you're going to be blocking that inflammatory healing response. So same exact thing that I've always talked about. These drugs are really not very helpful either for patients in the long run or for a regenerative medicine procedure. Amity Rehab. Is it possible to inject C0C1 facet anterior capsular ligament without undergoing PICL? 2, is it possible to inject C1C2 facet anterior capsular ligament during PICL? We do both of those on the capsular ligaments if they're indicated. We do a lot of 0-1 facet anterior capsule, but also the anterior AO ligament, which is right there. Could we do it without PICL? We could. If there's any kind of instability, though, related to transverse accessory and alar, then since that's a chip shot from there to those ligaments, if someone knows what they're doing, then might as well add the PICL. But yes, it could be theoretically done without. Although that is, realize PICL stands for percutaneous implantation of the craniocervical ligament. So that's a craniocervical ligament. But I think what you're talking about is, do you need to inject the alar accessory transverse? And the second question is it possible to inject the C1C2 facet anterior capsular ligament during a PICL? Yes, we've done that quite a bit. So that's pretty easy to do. 3, is it possible to safely perform dextrose prolotherapy injections on posterior facet, C0-1-2-3 facet capsular ligaments without using DSA by level 1-2 providers? No, it's insane. So that would be an insane thing to try, to inject the posterior portions of 0-1 or 1-2 without imaging guidance, which would need to be in those areas, fluoroscopy, and digital subtraction angiography. So that's just asking for trouble, Amity, at the end of the day. Listen, it might be fine, but that's one of those things where it's all good until it's not fine. And I think I've told the story of an experienced interventional spine provider in the Northeast who saw one of our patients. The mother was told to bring that patient only to Colorado, not only because those injections shouldn't be done outside Colorado, but because this was a really hard patient to position. And, they ended up sticking the needle in her brainstem, and she's probably now permanently damaged and injured as a result of that. So at the end of the day, that's just a bad idea waiting to happen. Kelsey, I'd actually see you mentioned age as a relevant factor for some of these measurements. Are other patient differences such as size, frame, sex, etc. relevant? Yeah, it's a good question, Kelsey. I do think that there probably is, within all of this data, sex and age or sex and size based differences. So it isn't tenable to believe that a 6'5" man would have the same measurements as a 5'1" petite woman. Having said that, none of these studies are broken out that way, mostly because they don't have enough data to break it out that way. So if I do a really good imaging study, I might have 50 normal controls. And if it's an excellent study, maybe I've got 100. Well, I can't break 100 patients out based on their physical size, because if I start doing that, my number of patients is going to go so small that I'm going to go below statistical significance looking for the differences. So might one day someone do that study? I agree with you. It really needs to be done, because it's hard to believe that the same measurements that apply to a 6'5" giant man apply to a 5'1" petite woman. So what we've got right now instead are the amalgam measurements that take all of that into account. But you'll get no arguments here. I think those studies do need to be done. Cynthia, when you say you go beyond the criteria and talking about clinical diagnosis, do you mean symptoms? Not sure what you mean there. I think what you're talking about is, I put a statement in there, if we go beyond our own imaging criteria, we disclose that to the patient. So a good example of that for us would be adjacent segment disease. A patient walks in fused from C3 to C7, and they're having upper cervical symptoms. They don't have CCI, but it's very clear that the upper cervical spine is getting overloaded and needs to be tightened down. So that would be a PICL candidate based on the clinical diagnosis, even though they may not have CCI. So I think that's what I was talking about. Johnny, I took a DMX with Dr. Katz that showed some laxity. I'm waiting for my appointment for review. What can I do in the meantime? I've had several C1 misalignments recently. Johnny, not sure which appointment you're waiting for. Are you waiting for an appointment to see if you pass the pre-screening criteria for a telemedicine? Are you waiting for an appointment with a provider? You know, the best thing to do usually, Johnny, in general for most patients would be to find a good upper cervical chiropractor who can keep you in place. I don't know if you've already tried that, because this is more of a general or a general discussion on my side. Ray, how do you see the correlation between patients with a MTHFR gene mutation, their ability to heal or speed of recovery from EPICL? No, Ray, we don't have enough of that testing right now to make a go of that in the current database. Maybe as all of that becomes more routine, we will. So there may or may not be a connection there, but that would certainly be something good to look at in the future. Snowmass, what symptoms do you look for needing upper cervical capsular injections? Snowmass, realize, and I've said this now multiple times, capsular injections are a figment of the imagination of providers who don't have the skill to do these injections properly. And here's what I mean by that. At the end of the day, facet capsules can be very easily injected if you're injecting inside the joint using X-ray guidance and contrast confirmation. So inside a facet joint, for example. You simply inject on exit and you've injected the capsule quite nicely. But where this term comes up is when someone does not have the training to put a needle in a joint and confirm with contrast that they are there. So what they claim is that, well, they're not injecting the facet joint, they're injecting the facet capsule. They're not injecting the facet capsule. That is, if you believe that, I've got some swampland in Florida to sell you, and the deeds are in my trunk. And what I mean by saying that is that that's a euphemism for, I'm going to put the needle somewhere in the back of the spine. I might hit the facet capsule. I might just hit the bone. I might just hit the tendons. I don't know what I'm hitting, but I'll call it facet capsules because that sounds better. And it kind of hides the fact that I really don't have the training to do these procedures properly. So, so the answer is facet capsules are always injected when you're injecting inside the joint. And you should be looking for a level 3, 4, or 5 provider who can inject inside the joint, who can inject the facet capsules very easily, and also inject inside the joint. But if you're seeing a level 1 or 2 provider who is telling you that they're injecting the facet capsules, find another provider. There is no reason in 2025 to put up with 1950s or 1960s medicine of I'm sticking the needle in there and bouncing off the bone, and I have no idea what I'm injecting. SNOMAS, what symptoms do you look for needing lateral atlanto-occipital ligaments and also tendons at the skull base? No real symptoms, SNOMAS, but we do inject the anterior and posterior AO legs. I think you're referring to what we would call the posterior AO leg there, meaning the ligament that goes from the transverse process of C1 up to the skull. And then the tendons along the skull base there. Now, again, you can't inject those lateral AO ligaments with a level 1 or 2 provider. You definitely would need a 5 or a 5 plus because the vertebral artery is sitting right there. So there's just no way to do that with the kind of providers you're talking about here. So please don't fall for that. I do not want to have you come back here with a brainstem injury. The tendons at the skull base can be injected and frequently are if they're tender on exam and the patient is localizing pain at that site. So this is someone who says, you know what, I don't so much get headache pain that radiates up, but I get this right here. Now that could be a C1, C2 facet referral, but you're on exam, maybe the C1, C2 facet is not tender, but the tendons themselves are tender. And in that case, you would inject those tendons. NAVA, what if flexion extension and upright MRI hurts? Is it possible for these movements to hurt the patient or cause more harm, injury? I usually try not to move my neck so much due to pain. Yeah, NAVA, this is a chronic constant problem we see, right? Patients get into this fear avoidant behavior for a very good reason, where they don't want to, let's say, look left or look down, so they just don't do it. Now, after not doing it for a long time, they lose massive amounts of range of motion, and they literally can't get the range of motion needed for movement-based imaging. So regrettably, NAVA, I would tell you to get diagnosed early before all of that sets in, to take some pain medications or muscle relaxers during an upright MRI or other movement-based image. But you're right, you can push yourself into a deep, dark hole of, I can't move my neck now, so I can't get the imaging. And even though I may have CCI, no one can diagnose it because I'm in this place where I can't move my neck anymore. And that's a real practical problem that we see all the time. Hallie, does tightening ligaments and fixing alignment with postural physical therapy have some impact in restoring neck curve, or is curve correction therapy always necessary? Yeah, Hallie, I would say it's usually necessary, but not always. So again, the best I can do in talking about this stuff is to talk about how most people would respond. So for most people, I would say they would need to do curve correction on top of those things. Nava, I saw in a Reddit post that a patient thought he got more injured during the flexion extension movements. It's definitely possible. Like I said, if patients have pushed themselves into that deep, dark hole of I can no longer move my neck, and they haven't gotten intervention so that they're in this place where they can't move their neck, that could certainly happen. So that's why I'm here as an evangelist for this diagnosis, as an evangelist for early treatment, trying to get the message out there, hey guys, this is a real thing. Try to get it diagnosed, try to get it treated before you get to that spot. Greg, thank you for taking your time on a Sunday and other times to help better inform the community. Very helpful. It makes all of this feel less isolating. Well, thank you, Greg. I appreciate it. As you know, yes, I do this on Sunday mornings. Woke up at 4, checked the Reddit. Reddit sub RPICL. I've spent lots of time I probably check the Reddit sub and RPICL 30, 40 times a week. I do that even if I'm on vacation. So I'm about to go on sabbatical. For my fall sabbatical, I'll be gone for 6 weeks in Europe on the ocean there. And I will probably still check that Reddit thread 3, 4, 5 times a day, because it's important to me that I keep the information train going, because that helps people in the long run. Even if I never see them, it helps people in the long run. Will flu vaccine affect recovery from EPICL? Not usually, not something we would be concerned about, Vivek. S. Dennis, appreciate all the info you've produced lately. Well, thank you. I work hard doing it, try to make sure that everybody gets a chance to learn, because again, patients that know more can protect themselves better. Patients that know more get better quickly and are less likely to go down rabbit holes that just cost them time, energy, money, and resources, or could put them at risk. Edgar, do all reference measurements get evaluated routinely during a telemed with CSE physicians provided DMX standing flexion extension MRI? Is there value in any other type of imaging? Yes, all of that routinely gets measured, and all of that goes against those standard measurements that I discussed, including that table that I'll put on the PICL sub. Is there any other value for other kinds of imaging? Not really. At the end of the day, I think 98% of this can be covered with DMX and upright MRI. And if we needed something beyond that, then we would be happy to discuss that on a case-by-case basis with the patient. Dennis, when did you start grading or sorting types of CCI? I telemed with you in late 2019 and can't find the type that I have. Let's see, Dennis, when did I start that? That's a good question. Like most people, I'm probably going to always measure my life now as pre-COVID and post-COVID. So that would be pre-COVID. And was I doing it pre-COVID? I want to say that I probably started it around 2020 or 2021. And it was born out of more necessity, right? At the end of the day, we had a situation where, unlike a surgeon that would just go fuse the whole thing, we were trying to hit specific ligaments, but we needed to know which ligaments to hit. So for instance, in a type 2A, you're focusing on that transverse ligament, or you better make sure you cover that. In a type 2B, you're focusing on that accessory alar ligament, or you better make sure you're covering those. In a type 1C, it could be lots of different ligaments, including that anterior capsular ligament or anterior AO ligament, as we would call it. You better make sure you're covering that. So that's really where that was born out of, Dennis. So at the end of the day, you were probably in before that. Cynthia, can you give us a description of what a damaged ligament looks like on an MRI? Madera's MRI at the den showed her right alar area was completely black, her left AR gray, puffy, thickened. Yeah, Cynthia, so that's a hard one. It's a hard one because, yes, there are some standards for what damaged ligaments look like on MRI. However, these ligaments are very difficult to image. And consequently, you're really not going to get an immense amount of information from the average MRI of this area. Now, there are types of MRIs we can perform where it's an upper cervical MRI with a head coil and a 1.5 or 3 Tesla magnet. And we have the slice thickness set at a certain amount. And we have the imaging sequence chosen so that we're going to enhance the ligament. But that's still not going to give us as much information as stressing the ligament to see if the ligament is functioning correctly. So even in that situation, very advanced imaging, which is what 99.99% of the images I look at are not. But even if we had that, we'd still be at a loss, because if the ligament didn't look right, then it still needs to be stressed to see if it works right. So there's look right and works right. Works right always trumps looks right. Cassian, have you ever seen any improvements in functional GI disorders with treating the thoracic spine? Not really, no. I mean, again, Cassian, realize that most of the patients I'm seeing these days are craniocervical instability. And we have functional GI disorders that are getting better because we're treating the upper cervical spine. But as far as the thoracic spine, no, that would be much, much less common for me to see just in my overall clinical experience. Lewis, doctor, what imaging studies are needed for working up hypermobility in the thoracic spine? Usually not an imaging study. So that's going to be a clinical diagnosis because it's hard to get good thoracic movement-based imaging studies. So nothing in specifically now having a thoracic MRI to look for disc bulges, areas where the nerves might get irritated. That's helpful, but it's really going to be a hands-on exam of the thoracic spine that, for example, helps me identify rib instability. John, who does all of these measurements? John, we do all of these measurements in a telehealth. As far as a reading radiologist, that's going to be hard to find. I think most patients would tell you that they usually don't get these things measured on the MRIs that they get done. Now, you might find very specialized centers like Med Serena in London or this Colorado facility here for upright MRI, where they do measure these things routinely, but that's sort of few and far between. Claire, have you treated anyone with injury to the neck muscles that caused their CCI? I had TOS surgery and chiro accident, which caused instability, but my CCI symptoms began 2 years after. So I think what you're talking about is the TOS surgery would have taken out presumably the scalenes, and that could lead to more instability because they're one of the secondary stabilizers of the upper cervical spine. And then the chiro accident kind of pushed you over the edge. So yes, I think that's certainly possible. Snowmash, ChatGPT says wearing a brace is a good idea after treatment to protect the ear for 12 weeks. What's your thought? Again, Snowmash, these are low signal environments, so you have to know how large language models work or you're going to cause more problems than solve, meaning that ChatGPT or any large language model or transformer model works by they feed it the internet and then it's a next word prediction engine. So if there's a lot of signal out there, i.e. if we had hundreds of doctors and hundreds of papers talking about whether or not you should wear a cervical collar after a regenerative medicine injection, and there were 25 studies on it, then ChatGPT would be accurate because it would have learned all of that information. But instead, we're in a low signal environment here, meaning that there's just not much information out there about wearing a brace after a regenerative medicine injection. Hence, ChatGPT is going to make up as much gibberish about that as it would accurate information. So listen, I love large language models and generative AI, i.e. transformer architecture AI. I use it a lot, more this year than last year, because this year the hallucination issue finally got tamped down. And we'll use it more going forward in my work. I also use it for data analysis, for example. But for stuff like this, that's a bad use of a large language model because there isn't enough information out there for ChatGPT to give you an accurate answer, basically. And Freddie, after some recognized trauma to cervical upper ligaments, how fast do you need PICL and other injections to fully recover you? How early has to be the treatment? Yeah, so literally what we tell patients is we would prefer to treat someone within that first 12 months of injury. So you're going to want to give this time to heal on its own. You're going to want to give this time to respond or not respond to conservative care. So on the minimum side, meaning when I had doctors, and I've had several who have had this, and they knew what it was early, they were getting treated at around that 3 or 4 month mark, right? That's enough for normal healing to occur. They nailed the diagnosis within the first month. They tried everything conservative they could, and they were getting it at month 3 or 4 for treatment. So in the perfect world, that's what this would look like, right? You had someone who identified it week 2. This is what I have. But you've tried to give it a chance to heal. So, those doctors who had it would be perfect world. They knew what it was. They knew all the things to try. And they knew immediately when those things didn't work at around that 3 to 4 month mark that it was time to get in and get treated. And consequently, they only needed a single treatment and they were done because they didn't allow enough time for this to damage other structures. And so they got a single treatment. They moved on with their life, never had another problem. Edgar, for CCI type 3A, you typically inject the PLL, or do you typically inject the PLL in the upper and mid cervical during EPICL? The PLL, the posterior longitudinal ligament, if we're doing an EPICL, can be injected pretty easily, yes. And we'll get as far down as maybe 3-4 pretty routinely there. Now, injecting the PLL lower than that is not worth it because in order to do it, you'd have to go intradiscal through the disc into the PLL. And the risk for that is too high. There's just no reason to take that risk in most patients. John, what if a patient has too much pain and restriction? Yeah, so John, I think we talked about that before, so I think I answered that one. Snowmass, it's unfortunate people did not have these information early to know what is best, like blind injections of Botox. Botox is still very much recommended without questioning if you're hypermobile. Yeah, Snowmass, that's why I put out all this information. I just put out that whole injection series, level 1, 2, 3, 4, 5, which I saw you were referencing, so that's great. At the end of the day, the goal here is to educate people. Listen, I'm doing my part. I work hard at this, as you all know. And I'm trying to get the word out there, but we still have a lot of misinformation. I still see patients who shouldn't even be trying posterior injections, go down that rabbit hole and they waste 30 grand doing it. I still see patients who waste 20 grand on blind hunt and peck injections that are high risk and, make no sense. So you're right. In the perfect world, we'd get information out to everyone about all these things, but, I'm certainly doing my part. Mark, I referring to replacing the fusion with Mobi units. Dr. Roy in LA, California does this. I'm not quite sure what you're referring to. If you're referring to something like a 2, 3, 3, 4, 4, 5, 5, 6 fusion, I think you're talking about an artificial disc replacement. That's a type of artificial disc replacement device. You can do it that way, but regrettably, it doesn't really work. At the end of the day, it's no different than a fusion based on the existing literature. As far as in the upper cervical spine, you can't do that with a Mobi ADR. Ben Freddie, quick rotational movement of the head and neck can carry the risk of cervical fracture, unable to see standard x-ray. No, if you're getting a cervical fracture from quickly rotating your head, then you could have cancer with metastasis to the bone. But as far as in a normal patient with normal bones and ligaments, that does not happen like that. Mark, are you still of the opinion that if my transverse ligament has calcification, it's too late for injections? Mark, I'd need to know in context what that is, right? So we'd have to do a full telemedicine, have to see how much calcification we're talking about, where is the calcification, is that causing you problems, is the problem coming from something else, all of that stuff. Mark, Dr. Landman does fusion reversals. Again, Mark, there's no way to reverse a fusion. Now, you might be able to take it from a fusion to an ADR, but you're kind of robbing Peter to pay Paul there, meaning that you're not really gaining a lot by doing that because those ADRs function as fusions based on the literature. But you can't make a new disc, so you're never going to be able to reverse a fusion. Johnny, waiting for an appointment with you or Dr. Schultz. Gotcha, Johnny. Stephen. Stephen. Yeah, Stephen is one of my early German patients from way back. So great to hear from you, Stephen. Hello, Dr. Centeno. I just wanted to reach out and thank you again. PICL was the best decision I've ever made in my life. I want to help take away the fears and doubts of anyone who may need it. If you would like, we could do another live call where I can share my improvements. Thank you so much. Yeah, Stephen, that would be a good idea. It's always good to do some Facebook Lives with former patients so that they can talk about their experiences, and certainly with that German patient population as well. You can obviously speak to them in ways that I can't, not being a native German speaker. Let's see. HFBHJ, pretty sure Dr. Henderson has said that the Atlanto-occipital capsule is important for growth stability based on cadaver dissection studies. Same thing with alar ligaments. C1C2 capsules seem useless. Yeah, I think we're talking the same thing here when it comes to, so realize that we're talking about two layers of things. So the first would be C0, C1, the second would be C1, C2. In addition, the next layer down would be, if we're talking about anterior C0, C1, there's a anterior capsule, but there's also a strong ligament there as well that's just superficial to that capsule. So between that strong ligament in front of the capsule and the capsule, that is very responsible for 0-1 stability. In addition, 0-1 stability is also determined by the depth of that 0-1 joint, which is what I've discussed in the measurements earlier. And then I would agree that the C1, C2 capsular ligaments are fairly useless given the extreme amount of motion that C1, C2 can produce. Let's see. Have you ever performed a PICL where you only inject the alar ligaments and nothing else? Certainly done a PICL where we've only injected the alars. But again, that's a discussion with the patient, right? At the end of the day, is there a rationale to do only alars? If you're going to do alars, you probably want to do accessory because they kind of have crossover functions, for example. But that can be a discussion with the individual patient. And Freddie, what should you do in acute to try to heal your ligaments after 3 months of the cervical trauma if collar doesn't help? Yeah, so Manfredi, that's when you want to start getting diagnosed, right? That's the window I was talking about before. In a perfect world, you can, in a perfect world, at around that 3-4 month mark is when you would want to start getting that diagnostic treatment train going. Matt, are these live streams recorded? They are. And yes, Matt, so if you just go to the YouTube channel, it'll be there forever. It is under the live section, which is something I didn't know about until about a year ago. I didn't even know there was a live sub-tab there, but there is. It goes something like home and then videos and then or shorts and then live, or live then shorts. You got to go to the live tab there. And great to hear that you're healing well. Thanks so much for that update. Okay, guys, well, I got a whole bunch more questions, and I'm at 1 hour and 18 minutes. And I got to get myself some caffeine here. So I'm going to take just the more interesting questions going forward that I haven't answered before. Dennis, have you ever helped patients to get Social Security disability due to CCI? Dennis, we don't get involved in the Social Security slogfest that it has become. But we certainly, give patients our records. If they have CCI, obviously that's in there. And that can be helpful in trying to do that. Oh yeah, I've seen this one. Watch out for that healing is free Doc Smith guy. Complete idiot that can hurt CCI patients by telling them to balance heavy objects on their head. Yeah, I think this is an important one because I've seen a couple different things that aren't great for let's say, for the average CCI patient, right? There are CCI patients who could balance things on their head. There are CCI patients that can tolerate neck weights. There are CCI patients that can use an iron neck. They're more at the margins, though. If you're talking about the average CCI patient, telling the average CCI patient to balance something on the top of their head, or telling the average CCI patient to use an iron neck is sort of a prescription for disaster. But again, you will see people at the margins who are that functional where they can do stuff like that. Let's see. Is the angle of lateral bending while replicating DMX with static X-ray crucial for objective measurements? Yeah, the biggest issue there, Vedam, is you want to get as much lateral bending as humanly possible. And then take the X-ray, right? So it's open mouth, as much lateral bending as humanly possible. And you've got to have the head rotation dialed in, because when you go to bend, you want to rotate your neck and you have to keep your head straight. So it is important to get as much lateral bending as possible. Let's see, something I haven't answered here. Do I think PRP and BMAC can help kidney disease? I don't know. Not my area of expertise, but I can tell you that PRP is routinely now used in fertility. PRP is routinely used now in hair loss. PRP is routinely used now for cosmetic stuff. PRP is routinely used for other disease states with randomized controlled trials showing it's effective. So I wouldn't be surprised if someone tries to use it for that application at some point, because there's lots of crossover applications for PRP outside of musculoskeletal. Okay, guys, well, I think I've hit all of this stuff before. I want to thank everyone for taking the time to be with us today. And again, give us a like if you haven't already, because that's how patients find this feed. And if you think this is important to you, if you think this may have helped you, then give us a like, because at the end of the day, we want to pay it forward in the CCI community, make sure more people can find information like this. But thanks so much for spending a Sunday morning with me, or depending on where you are, it might be just afternoon. And I will be back here. I should be back here next week. Yep, I'll be back next week. I've got a conference I'll be lecturing at, but I will be back by Sunday to be able to do this, and we'll do another interesting topic. So thanks so much for all the great questions. There are no bad questions here. All questions help us learn. And I will see you next week, and have a great week. Thank you.